Thank you, sir, and all the dignitaries on the dais, all the people who have come to attend this session early in the morning. Can I have my slides? Yes. So I'll be talking on CSR where we are today, since there are a lot of general ophthalmology sitting, so I thought I'll just brush up. CSR basically is an idiopathic disorder. There's a serious detachment of the neurosensory retina with alterations in atrophy of the retinal pigment epithelium. There's a thickening and dysfunction of the choroid, as Dr. Lalit said about the pachychoroid. Patient may present to you with blurred vision, metamorphopsia, macropsia, reduced contrast sensitivity, and scotoma. They are usually young and middle-aged males with type A personality under stress, maybe using steroids anywhere in the body, either inhalational or even on the surface, applying steroid creams. And it is commoner in Asians, but if it occurs in blacks, it's more severe. The changes of the choroid, there is a choroidal hyperpermeability, which can be demonstrated in both eyes, even if the CSR manifests in one eye. So there's a relevance to the multimodal imaging, and that is where the importance of pachychoroid comes in. You can have fibrinous exudation and the neurosensory detachment. You can have enlarged blood vessels. And you can have hypofluorescence or fundus autofluorescence. That is because of the fluid present there. You can have leak, which can present in, which can be unifocal, multifocal, and in various forms, which we have all learned in the past. And this is how it looks like after treatment, and you can have RP atrophy because of the treatment itself. So there is a stepwise approach to the management of CSR. All patients who come to you initial period of 3 to 6 months, you are going to observe them, talk to the patients, reduce the stress, stop all steroids. Prompt laser treatment at this stage does not improve visual outcome and may actually induce a choroidal neovascular membrane secondary. We have to manage the risk factors like smoking. We have to counsel the patient well. But then we have numerous treatments available. These could be divided into medications or lasers. Medications can be systemic or intravitreal, and lasers can be thermal, PDT, and a subthreshold micropulse. I have got experience on the micropulse laser treatment, so my talk would be to some extent stressed by that. So this is a small series which we had done some years back of observation of central serous retinopathy, which are acute CSR. You observe them, follow them up for adequate period of time, and they reasonably do well. Now it's a list of systemic medications. I will not read out through the details, but these have all been tried. There are numerous publications on each one of them, but one which is of some relevance is the mineralocorticoid receptor antagonist, particularly spironolactone and eplerenone. Both reduce the subretinal fluid and the choroidal thickness, but the visual acuity change is not statistically significant. They are both almost equally effective, but spironolactone has got certain side effects like hyperkalemia, gynecomastia, reduced libido, and menstrual changes. Now, intravitreal injections of VEGF have been given by people because VEGF apparently is given for all indications, including pterygium. But there is poor evidence of utility. It is only indicated in presence of a secondary CNVM. In patients who do have a secondary CNVM related to CSR would require about 4 to 5 intravitreal injections over the period of 1.5 years, as compared to about 12 to 13 injections in cases of age-related macular degeneration. We've been all doing thermal lasers, which has been done with the predominantly green laser, but we have now Navelas laser. For an extra foveal leak, you could use a thermal laser. Coming to PDT, we have had a full dose PDT, half dose PDT, and half fluence PDT. Basically, it's an intravenous injection of a photosensitive dye, which is waterpoffin. And I will not go through the dosages, which we know there's an activation of a laser at 689 nanometers, which is used for 83 seconds, and we've been doing it for a long, long time. Unfortunately, PDT is no longer available in the country. So it's difficult to have an access to it, but we should know about it, know about the half dose and half fluence PDT. And PDT is supposed to work because of vascular remodeling of the choroid and a decreased choroidal volume, permeability, and leakage of the fluid. It's been shown by a collaborative study published in ophthalmology, which was done by the Macular Society, which was a retrospective series of patients, of 237 patients, which basically showed that the clinical response to PDT treatment was not affected by the fluence setting. That means whether you do a half fluence or the full fluence, it did not matter. It did not matter the type of the leakage of fluence in angiography on corticosteroid exposure. So whether the patient was on or off corticosteroid, it did not matter. The visual gain was associated with a worse initial visual acuity. This is just an example of a patient who underwent PDT and responded well. What is important to understand that the post-PDT, the rate of recurrence was reduced to about 10% compared to no treatment. The recurrence rate was about 30 to 50%. PDT is equally efficacious, as I said, whether patient is on or off steroid, and continuation of corticosteroid at the time of PDT for some significant indication did not preclude a favorable response to PDT. Coming to the micropulse laser, this is a landmark study which was done by, which was a seminal study which was done long time back, which showed that the burn duration equal to damage. So if I reduce the burn duration, I could potentially affect only the retinal pigment epithelium. You can see here that as we reduce the duration of the burn, so initially we can detect it on the fluorescent angiography, then we may not detect it on the fluorescent angiography, and a micropulse technology basically breaks up a continuous wave into beams which are active for the shorter duration of time, like here is for 2 milliseconds, so it's a 5% duty cycle. So it is an on and off time, so the off time allows the tissues to recover. This is an example of a micropulse laser where you cannot actually demonstrate changes even in the OCT. Now there are 3 wavelengths available with the micropulse laser: a green wavelength 532, 577, which I have an experience of, and worldwide this is the preferred wavelength, and 810 nanometers. Now the reason which people disbelieve micropulse is they say, I don't see anything, so how do I know it works? So this was an immunohistochemistry which was done by a Japanese group, which showed that if you do a conventional laser and you produce a burn like this, it is the area around the burn where you have production of heat shock proteins. So if you have a micropulse laser, this entire area becomes an area where the heat shock proteins are documented, and you can see here they documented the production of heat shock proteins. You can see this change happening. So this showed that micropulse laser, when it is used, it does produce changes which are working at a tissue level, at a cellular level, at an intracellular level. And when a micropulse laser is given, there is production of an anti-angiogenic tissue restorative factor, and therefore it is known as a laser which is non-traumatic to the retina. It was after numerous studies which was found that a low intensity, high density laser is what is used. And this is one of the picture we had taken just to show you that how a Pascal laser in a micropulse works. It goes like this, comes down, goes like that, comes down, and you can do a 7 by 7, 5 by 5, or 6 by 6 squares. Here are some examples. This is a chronic CSR patient, 58 years old male who had CSR. You can find a multifocal leakage for about 14 months, treated with micropulse, responded very well. Another patient, a 63 years old male, 18 months chronic CSR. Again, this patient had been treated with micropulse, responded well. Here was a patient who was a dentist. He came to me after having CSR in both eyes for last 5 years. And his only complaint, he was not worried about 6/9 vision, but he was worried about metamorphopsia. He was an epineuron when he came to us. We stopped epineuron. We did an OCT angio, and we found that in his right eye he had features of a secondary synovium. You can have a flat PED with an irregular IP surface, a notched PED here, and a pachychoroid. We can find large blood vessels. In the left eye, he had a CSR with small PED, but no evidence of a pachyneovasculopathy. So this was when we could demonstrate a pachyneovasculopathy. We went ahead and gave an ILIA for this patient. This was in 2019. The patient responded, and in the left eye, I treated the patient with micropulse laser. Immediately 3 weeks after the laser treatment, actually his neurosensory detachment worsened, but over a period of 6 weeks it flattened off. So when a patient comes to you after micropulse laser treatment, even if the neurosensory detachment worsens during the initial 3 weeks, it does not matter because eventually it will recover, and I do not retreat the patients at least for 2 to 3 months. This is a patient who is an ophthalmology resident, who had come to me with a paracentral scotoma. So we treated him in his left eye, and now he has come over a period of last 1.5 years. And you can see that he has, whenever he develops a blurred vision, which is extra foveal area, he notices it. He's an ophthalmology resident, and he's doing well. Over a period of last 3 years, I've given him 3 treatments, and he's doing well. So this was a study which was comparison of micropulse laser with PDT. It showed that both are effective. This was a study done in India from NN, which again showed that micropulse laser yellow wavelength was effective in the treatment of chronic CSR. And then on a low fluence photodynamic therapy, when we compared it with a subthreshold micropulse laser, it showed that at the end of 1 year, micropulse laser reduced the subretinal fluid more than the PDT. We have to also remember the masquerades of CSR. So in conclusion, let me say that acute CSR, you must observe, stop the steroids, reduce stress, and treat other complications like patients should stop smoking, hypertension. Chronic CSR, I feel micropulse laser therapy, especially for the central leaks, in the 20 of the 19 eyes which we have evaluated till now, we have treated more, they have responded in our series completely. Can be repeated after 2 to 3 months. It is a safe treatment, causes no damage to the neurosensory retina. It is much cheaper than PDT and is very relevant for India. There is no dye injection. Octa can help us in detecting pachychoroid and the secondary CNBM, and this allows us for an appropriate treatment. I think micropulse laser is underutilized in our country. We can utilize it in more number of situations, and I think it is going to be effective. Thank you.
Thanks, Ajay. So, where are we today?
So, the protocol is very clear. If we have an
so let me ask 2-3 pointed questions because time is less and we have to summarize also. I think you have summarized it very well. Acute CSR, don't do much, masterly inactivity.
Correct.
You said reduce stress. That may or may not be possible depending on the, it's easier to say reduce stress. So
we have to counsel the patient.
Yeah, so counseling is easier said than implemented. And smoking and all that's okay, hypertension is also okay. But stress reduction is not so easy in today's world. Then coming to chronic CSR, if it's less.
So most important, they should stop steroids. We find patients that's very important.
Yeah. So in India, you have to also consider the role of these homeopathic and Ayurvedic medications and skin creams and all these things which you never know their constituents. And as far as chronic CSR, laserable, go ahead and do routine laser. If it is non-laserable, that means it is in central part leakage is there. At least for me, there is no role of, giving anti-VEGF injections. People still give anti-VEGF unless and until you have documented CNVM documented by Octa. My question was that today, where are we central leak chronic CSR choice? We will have, before I ask you, let's have from the panel, Gopal, are you here? Central leak chronic CSR, what is your choice? One word answer. PDT is not available now.
Yeah,
Issue is this.
PDT is not available, so I would consider, I would do a fluorescent definitely, look for any leak. But then
No, central leak, I'm telling you, central leak is there.
Okay.
Central leak, subfoveal leak.
Aplenerone or injection. I think intraocular injections or aplenerone.
So unless it's a pachy-CNV, aplerenone.
Aplerenone. Sangeet?
So I'll just observe.
Observe.
Yeah. And
Rajiv?
just explain.
Aplerenone, and
Yeah.
if there is a CNVM on OCTA,
No,
which you
CNVM
said,
is not, yeah.
then injection.
Injection.
So micropulse or injection?
Okay. Observation.
Earlier I used to, but now I shifted to eplerenone. First time, naive patient. I would definitely like to start with that.
Eplerenone, sir.
Eplerenone. Micropulse. So, I think it's 25% micropulse and 70% eplerenone.
So you have to ask everybody.
So
this
now
question.
therefore I'm coming to the master.
Do they have micropulse with them available?
So-
if they
so-
don't have, they will not do it.
I'm coming to that. So, people who have micropulse and they're not using it for this.
Yes, sir. I'm one of the example. Of
Yeah.
course, we use it in when the. So I just want to ask you the question: what you consider the height of the SRF? If it is too tall, if it is more than 400, 500 micron, we have very suboptimal responses we have seen. And the cases which you showed, sir, they were slightly of the lesser size of the height of the SRF was slightly slower. So what do you think is the cutoff point for doing micropulse in these cases?
So my cutoff is about 450 microns, but I've done it and more this thing. And see, the problem.
So you do it only at 5% of duty cycle. You don't increase the duty cycle.
With the macula in CSR. In my series, we have had almost about 98% success rate in CSR.
So in any case, Ajay, micropulse is not a cure for CSR. It is generally required to be repeated also.
Yes.
And I believe, I was talking to Pramod also, maybe 810, maybe because it's a choroidal disease now, 810 may be more useful and preferable if you're talking about reducing damage to the retina. And I presume and feel that TTT, what we used to do way back, as TTT is 810, could be also an alternate for that.
The only problem with TTT, sir, it is a damaging laser. Micropulse is not damaging laser.
Yeah. So as of today, anybody from the audience has any comment about only one point, chronic CSR, central leak, active?
I had the question that
No, are you answering this or?
experience treating central subfoveal leak with micropulse, and what are the results?
That's what he showed actually. He showed there. He showed in this slide.
And what is the rationale of ILIA or injection?
No, ILIA in all anti-VEGFs in pure pachychoroid in CSR without OCTA or FA documented CNVM, I don't think so anybody uses. CSR, pure CSR is not a VEGF-related disease. But if it has a component of CNVM based on OCTA or FA, then nobody hesitates to give anti-VEGF. But I am against using anti-VEGF in case it does not have any CNVM. Yes?
So chronic CSER with subfoveal leak, first observe. Second, I think the subthreshold also.
Rather, if you observe, patient goes somewhere else.
Yeah. But that subthreshold thing is also just a temporary modification of the underlying pathology, which is pachychoroid in most of these cases. So let us call it just a modifying agent and not a...
Yeah, because we used to have excellent results with PDT, excellent results. In fact, Ajay, you used to show one slide where PDT has been compared with micropulse.
Yeah. Better thing would be to compare the thickness of the choroid in those patients who have undergone subthreshold laser and who have not undergone. If the pachychoroid levels remain the same, then it is just a chance that your RPE has given way and therefore it has manifested as CSER.
Okay, let's ask Dr. Andy, suppose you have options for micropulse, you have options for PDT and eplerenone. So what will be your first choice? All these things are available to you.
I've not had good success with the eplerenone. I like PDT, and in fact, I don't even wait for it to get to the chronic stage. I think that it, as you've shown, it does reduce the risk of recurrence, and recurrence central serous is a problem, and I think that you get better results if you treat it acutely. So I don't wait any longer.
So there is a study.
Let's conclude this.
Let's conclude this.
Ajay,
which published in
Ajay, let's conclude this talk by saying, you see, first 2-3 categories are perfectly okay. All of us are bothered. I am not too happy with the statement that chronic CSR, subfoveal leak, if patient is disturbed, I don't think so. Observation is a good strategy to follow in such situations. And if at all, the bulk of evidence is in favor of either PDT or micropulse. And people who have micropulse, I think they shout from the top that micropulse is effective. And as Anand was saying, it's a disease modulating state. It's not a cure, and we may have to repeat it. And believe me, eplerenone does not have such bad results. As was presented in American Academy, they washed away eplerenone. And that is not true actually. You see, in a lot of personal experiences, eplerenone does work. It may not work forever, but till the time, it may take some time, but personal observation, and I have spoken to a lot of people, it does work in around 60 to 70% patients. If I agree with you, if you have micropulse, that should be the second question. If you have micropulse, then do you use it or not? And I think what Andy said and you said, we take it from you that micropulse in the absence of PDT, I think that should be